and thinking about whether there's any lessons for India on that work, and I hope to give the same talk when I go back to England. Tobacco control in India, are there any lessons for England? Getting used to the technology. So as a way of an outline for the talk, I'm going to give a brief overview of the FCTC and tobacco control policy in England. I gave this to a sort of general public health audience, so I realised that many of the people certainly here of great knowledge about the FCTC, much more than me, so maybe I'll go over that quite briefly. But you're possibly more interested in the tobacco control policy in England, and present some evaluations of a few of the articles of the FCT in England that I've been involved in. And then finally consider some strengths and weaknesses of tobacco control policy in England, and whether there are any potential lessons for India. And I hope that will trigger a discussion at the end so we can interact. So just very briefly, I'm actually born in Australia and been in Britain for the last 17 years. I was formerly trained in public health in the National Health Service between 2003 and 2007, and I've had a mixture of health service public health experience and academic public health experience. And I've been fortunate to have 2 stints abroad, previously in New South Wales working on obesity prevention, and more recently in California, where I spent a lot of time working on tobacco control. California is probably the most scariest place in the world for the tobacco industry, and so there's a lot to learn there and benefited from that. So I sit in the School of Public Health at Imperial College, and it's got a very strong epidemiological focus, but our particular department is primary care and public health, and we do more applied policy evaluation research. And what we generally do is use routine data sets through population health surveys or health service data to evaluate health policies, both within health systems and outside of health systems. So that's really our strength. And I've got a number of areas of work, but focusing mainly on tobacco control in India. So people will know why tobacco control is important. Obviously, it's a major contributor for risk factors for NCDs, but it's also good to remember that it's a major contributor to disparities, socioeconomic disparities in premature mortality between socioeconomic groups. The European data suggests it explains between 25% and 50% of the differences in premature mortality between poor individuals and richer individuals. And that social patterning is very much evident in India, as you're aware. So it's something always to keep in mind when you're both thinking about the epidemiology of tobacco, but also the effectiveness of tobacco control policies, is is there a differential impact on different socioeconomic groups? And in particular, is my policy intervention or health service type of intervention reaching those most in need in terms of wanting to reduce tobacco use, so the poorest folk? And we know it's one of the most cost-effective things we can do to improve health, tobacco control. So I'll just briefly go over the FCTC. As everyone's aware, certainly in this room, first global public health treaty, ratified now by 174 countries. India was at the forefront of efforts in terms of having strong provisions, particularly around tobacco advertising, and was the 4th country to sign up. The UK signed up shortly after in December 2004, but as yet the US, even the Obama administration, has not ratified the FCTC. So if you're looking for inspiration for tobacco control, maybe don't look to the United States, or maybe particular states of the United States, but not the United States generally. And it's likely that tobacco control is going to be a key area of called strengthening for NCD prevention come the UN high-level meeting in September. And I was just, out of interest, wanted to learn a bit more about what the FCT means and how it interrelates with a country's own sort of legislation. And pulled out this paragraph, which states that the FCTC lays down general requirements for countries, and those member states of WHO, with respect to measures they need to take in an area covered by the Convention, does not spell out specific rules to be enacted or implemented through national law. but indicates the nature of the legal, administrative, regulatory and other measures that need to be taken in accordance with national law. And it would be expected that parties to the convention would modify existing laws to reflect this, and that's obviously reflected in the Cigarettes and Other Tobacco Products Act in India. So let's get on to tobacco control in England. Hope you recognise that building. Yeah, Big Ben. So where are we in terms of where are we on the sort of smoking epidemic curve in England? Well, this is actually data for Britain. So I presented data here from 1974, where smoking prevalence overall was about 45%, and we're down to about 22%. Smoking prevalence peaked at around the time of the Second World War. In Britain, it was about 70% of men were smoking then. And we've had a gradual decline since then. So one of the questions that maybe we could discuss at the end is this sort of trend something which would be, projecting forward sort of 25 years in India, would this sort of trajectory be regarded as success for Indian tobacco control policy, or would you want something more rapid, given that we've got now an international consensus around tobacco control, and there's much more concerted action nationally and internationally on this issue than was the case certainly in Britain 35 years ago. My hope would be that you'd be more ambitious and would hope for more rapid declines, certainly in men. As I mentioned, that smoking is strongly patterned by socioeconomic status, and you can see here that the prevalence of smoking in the lowest income group is double that of the highest income group. But also I think it's important to note that there's a social gradient going on here, so that the second most poor or low income group actually has much higher smoking rates than the fourth group here. So basically this tells us a few things, that it's not only the poorest groups you need to focus on in terms of tobacco control efforts, you should also focus on those poorer and middle income groups as well, because there's certainly a burden there in terms of tobacco related disease that we'd like to address. So why look at tobacco control policy in the UK? Well, it's recently come out as faring or scoring well in terms of its tobacco control policies relative to other European countries. Now you may say Europe's not a good place, or hasn't necessarily had a strong history of tobacco control, and that'd be a fair criticism. So you may say that England or the UK is the best of a bad bunch, but certainly in terms of implementation of the FCTC and related metrics, the UK has recently come out as a leader in Europe at least. But it's worth noting that its implementation was behind that of a number of US states and Australia. So in terms of what we've done and when, we had a national white paper, government paper in 1999, and that set out that we would establish universal tobacco control, universal smoking cessation services from 2000 onwards. And they have been a very central plank in terms of our tobacco control policy. In 2003 we banned all tobacco advertising. In 2007 implemented smoke-free workplace legislation, and in the same year increased the age of sale to 18 years. In October this year we're banning the sale of tobacco from vending machines because it's a source of tobacco for youth that can be uncontrolled, and the tobacco industry has finally given up on that battle, so that's looking to go through. And from April 2012 larger shops will no longer be able to display tobacco in the shop, so the so-called wall of death will no longer be in existence in the large shops, and smaller shops will have it eliminated by 2015. And we're consulting on this issue of plain packaging of tobacco. And we're very much looking to Australia on this, because Australia is the first country that is seeking to implement plain packaging of tobacco. So this is what they're proposing. The colour is olive green, which apparently is the least attractive to consumers. And so you have an olive green colour. So this is the front of the tobacco package on the left and the back on the right. Very large pictorial warnings and a very small branding of the tobacco product at the bottom. So the tobacco industry is fighting very hard against the Australian government for this against this issue. They're using a bilateral trade agreement with the Hong Kong government to try and stop this happening. The Australian government feels that they've gone on sound ground to actually implement this on public health principles. But I think one of the messages the tobacco industry wants to send out is that if other countries are going to try and implement this, they're going to fight you sort of tooth and nail and very hard to try and stop this. They're just sending out a warning, even though they may expect to lose or may lose in Australia, that in other countries that they're going to vigorously oppose plain packaging. And in terms of recent taxation policy, we don't have this. We don't have the sort of variety of tobacco products that you do in India. In the UK, we mainly smoke tobacco. Not myself personally, but others. But there has been a price differential, and people have, particularly in the current economic circumstances where haven't got the economic boom of India, we're very much in the doldrums economically. So, and that's reflected in many people's personal income. So people are trading down to cheaper tobacco products. So as part of the 2011 budget, there was a concerted effort to reduce the price differential in tobacco products. So over and above a general 2% above retail price index, so inflation increase on tobacco, there was a 10% increase on hand-rolled tobacco, such that it's around £7.35 for, what's that, about 500 rupees for a 25-gram pack. And economy cigarettes were, there was a higher levy in terms of the increase in tax on those, such that the price differential between premium and economy cigarettes was reduced as a result of the budget. So less scope to for people to trade down to cheaper products. So what do we do with our tobacco control money in England? This is an estimate of the 2009-10 expenditure. The UK has some of the highest taxation on tobacco products in Europe, and what that leads to is the tendency to for people to want to smuggle tobacco in from other European countries because it's become very lucrative for criminal gangs to do so. So they've had to spend a lot of money on trying to secure border protection and stopping sort of the smuggling of tobacco. So that's quite a lot of expenditure there. As I said, there's a lot of emphasis on providing smoking cessation services, and including subsidising drug prescriptions such as NRT and more recently Champex. And it's interesting, you look at the amount of money spent in 2009-10 on one drug, it's double the amount we spent on mass media campaigns. So this has sort of led some to criticise the UK, and we've got too much emphasis on cessation services and not enough emphasis on sort of the broader sort of creating an environment where tobacco control is, or supportive environment for tobacco control through mass media campaigns and supporting other outside of healthcare policies. I thought I'd put up the money we're spending, or estimated amount of money we're spending on smoke-free workplaces in the UK. That's nothing, and this is the place we want to get to in India, where smoking in public places is no longer a social norm, and that doesn't require sort of police enforcement, doesn't require any other way of in the way of resources, and just seeing some of the sort of baseline data for steps. I think we're some distance from that just yet, but there's some room for optimism in terms of the situation in India. To put this in perspective, so we spend about £100 billion on the National Health Service healthcare expenditure each year in the UK, and we raise £9 billion through excise on tobacco each year in the UK. So there's certainly scope to increase the budget on tobacco control. We've had a new government that was sort of came to power in 2010 in May, and interestingly, they within 1 year or just over a year of each other, they produced two different tobacco control papers. The left-hand side is the Labour government prior to their election loss, and the new tobacco control plan with the new government. And basically, we're very good on setting targets in the UK. We don't often meet them, but we like to set them. Although the new government's called them aspirations, so probably using more or less strong language in case they don't meet those targets. So you could say in general the new government's targets in terms of percentage of overall or the prevalence of smoking are probably a little bit less ambitious. I mean, the time frame's shorter, but not as ambitious as the previous government. And interestingly, given this socioeconomic difference in smoking that I mentioned, they've removed any language about trying to reduce the relative rate in terms of manual or non-manual, low income and high income people, which is disappointing, because, as I say, this is the main sort of important area to reduce smoking in the poorer groups. But there's also a focus on further reducing smoking uptake in young people, and also we've got a big problem of smoking use in pregnant women, particularly again in the poor groups, so that 40–50% of pregnant women in some areas are smoking throughout pregnancy, and obviously that's an issue in terms of infant health that you're all aware of in this country. So I thought I'd focus on 4 articles of the SCTC. And start with Article 14, so demand reduction measures concerning tobacco dependence and cessation. So as I mentioned, we had a National Smoking Cessation Service introduced in 2000, and this has 3 levels. Firstly, it's encouraged that any healthcare professional provides very brief advice to anyone that they come across in a consultation that's a smoker. That's literally, are you a smoker, yes or no? If you are, try and quit because it's obviously harming your health, harming your children's health, etc. Then there's a separate group of people within our primary care facilities that have been trained specifically to provide brief interventions, around 5 to 10 minutes, to people, so they can be referred by anyone, say in the primary care clinic, go and see our specialist sort of person, be it a nurse or someone who can provide you with a bit more detailed advice and intervention. And then there's level 3, which is more the specialist clinics, where hardened smokers, people who are particularly dependent on nicotine, can have either individual or group therapy over a number of weeks, and would be supported by cessation drug aids. We've got, given that this, we've got this socioeconomic gradient, there's a desire to have more of these clinics in the deprived areas, that's meeting the need. And that also we've got subsidised prescriptions for these medications. So currently we pay about £7.20 for each prescription in the UK, but actually you're exempt if you're poor, if you've got certain conditions, health conditions, if you're elderly, if you're a child. So many people are exempt from these charges in any case. We know that certainly compared to other medical interventions, smoking cessation advice is one of the most cost-effective things we can do, and that's, I've just quoted some figures on the incremental costs of per QALY gained for smoking brief advice by healthcare professionals. So it's highly cost-effective. This is the threshold that we tend to use in the UK in terms of whether we endorse or decide to implement a therapy or a treatment or an intervention in the UK health system. We generally have a limit of £30,000 per QALY gained, and you can see that the QALY gain from brief health advice actually is much lower than that. So it's considered very much a cost-effective thing in the UK to be doing this. But in practice, and I'm not sure this is so much the same in India, our healthcare professionals don't naturally align themselves with being, advocates of smoking cessation, don't often spontaneously mention cessation to their patients. And in a systematic review published in 2005, gave some ideas about why that might be the case. Healthcare professionals often thought that it's too time-consuming. I haven't got the time to be talking about this issue, and I've got to treat people's colds and runny noses and those sorts of things. They didn't necessarily think what they did was effective. Giving advice, is this going to help change this person's smoking habit? And they felt they lacked the required skills to address these things. So if you can address some of those things through training or reassurance, then I think that's important in terms of trying to get your healthcare professional workforce to be on message as far as delivering smoking cessation advice. If all else fails, you can offer in financial inducements for them to do this, and that's what we've done in the UK. We started a new contract with our general practitioners in 2004, where smoking, along with a whole host of other aspects of chronic disease management, were incentivized. And so we had 3 smoking indicators in this financial incentive package that we offered. It's called the Quality Outcomes Framework, or the QOF. So records 23 was that practices had to have 90% of patients, and we call patients, but actually what we term patients in the UK, anyone registered with a practice, really population. 90% of patients aged over 15 years whose notes record smoking status in the last 27 months. So that rewards, if practice achieves that, they get 11 points. And each point is worth £125 for the average size practice, so it's about £1,000 for that indicator. Then we move down to smoking 3. This is very much focused on patients with chronic diseases, so diabetes, heart disease, hypertension, who particularly could benefit from stopping smoking. And there's 30 points attached to just providing or documenting smoking status in the notes, and an additional 30 points for actually providing cessation advice to those patients. So a much larger weighting towards providing smoking cessation advice to patients with chronic disease. You may say that that balance is not right because we want to actually get everyone stopping smoking, but they've decided to focus on those patients with chronic disease more so within this incentive. I did a little bit of research as part of my PhD to look at the impact of this incentive on the provision of cessation advice. And this is just on diabetes patients in a small area in London. And I documented smoking cessation or smoking status ascertained before and after the introduction of the financial incentive in 2004. And you can find that the percentage increased, so that 68% of people with diabetes had their smoking status ascertained in 2003. This increased to 87% in 2005. The percentage that were offered smoking cessation advice increased from 48% to 84%, and that smoking prevalence decreased from 20% to 16%. Now, that last figure sort of need to be treated with some caution because it may be due to improved recording of smoking status in non-smokers, and also, that we've got a trend of reducing smoking prevalence in the UK. But at the same time, there's some evidence that smoking prevalence was reduced in this high-risk population. So moving on to Article 16 of the FCTC, sale to and by minors, we introduced, like you have in India, an increase in the legal age for the purchase of tobacco in October 2007 to 18 years. The enforcement of this was seen as quite variable. We didn't necessarily have a huge resource gone into enforcing this. So I was interested in 3 research questions here. Did the law reduce access to tobacco? So could they purchase it as easily? Did the law reduce youth smoking levels? And did the law increase disparities? Sort of had a hypothesis that even if enforcement was fairly uniform in poorer and affluent areas in the UK, that because poorer children have greater access to tobacco through their social networks, through their families, etc., then they'd probably be able to source tobacco from elsewhere other than shops, and so the law may have had a less of an impact in this group. So looking at that first question, we've used data from what's called the Smoking, Drinking and Drug Use Survey, which is an annual survey of young people in schools. And it's like the GYTS, it's conducted in the school, and we find actually that leads to more honest answers about tobacco, alcohol and drug use than is the case in our other national survey, which is Health Survey for England, which is equivalent to your NFHS, which is actually asked in the home, and so children will, if their parents in the next room will tend to say, I don't smoke when I do. So I'll send them under report. So this is a better survey to use. So what we did here is I divided, in order to get an idea of how the policy impacted the poorer children, we have something called free school meals in the UK, where children whose parents are on lower income or unemployed are eligible to get free meals at school. And so I looked at them separately from the rest of the sample. And if you compare 2006, which is the year before the policy, in 2008, you can see that in both groups, the percentage actually reporting that they usually bought cigarettes from the supermarket decreased quite sharply, and was the same for garages as well. This is like where you buy petrol, we call garages. But for newsagents, so there's much smaller sort of shops, the compliance wasn't so good. So it shows the value of actually looking at compliance in different types of venues, as has been done with the smoke-free legislation here. But there was an increase in the number of children reporting that they received tobacco from either a friend or relative or someone else, which may have been an illicit source of smuggled tobacco, for example. But overall, it didn't seem to be that the poorer kids were actually any more likely to access tobacco from friends or relatives or someone else than the rest of the sample here. So this graph just illustrates actually that we've got a trend of well, certainly for periods of the study, of declining tobacco use. And so what we have to do is take that into account, because if, you know, in the UK, for both adults and children, we've got an underlying trend of reducing smoking prevalence. And so if you're going to evaluate the impact of a new intervention, you need to take that into account, because otherwise you may attribute a reduction to actually the underlying trend rather than the intervention itself. So we tried to do that with the analysis. So what we did is we pooled 6 years of cross-sectional data. We dropped the year, which is 2007, when the law was implemented. And we saw when you had one post-law year, which is 2008. So you can see we've put a year variable in there, which is basically taking into account this underlying trend. And I've highlighted in red the important effects that we found. Firstly, that the introduction of the law led to a significant additional reduction in tobacco prevalence amongst our young people in the UK. And then I fitted an interaction term between law and free school meals. And this suggested, because it overlapped, the confidence interval overlapped with 1, that you can suggest that actually it didn't have any different effect in poorer children as opposed to children overall. So it appeared to be have a neutral, so a positive effect overall, and was neutral in relation to disparities or inequalities in tobacco use amongst young people. So Article 8, move on to Article 8, protection from exposure to tobacco smoke in public places. So smoke-free public place legislation was implemented in the UK in England rather, in July 2007. After some sort of delaying by the government, first of all, they were concerned that that the public weren't receptive to this, that they should allow local governments to make the decision, not to make the decision themselves, and that the underlying line was that they're very much concerned about being described as a nanny state. This is a great sort of concern of politicians in the UK, where you're introducing state control into people's private lives, and that we have a very strong right-wing media who is very much on this topic and will very much be strong against governments who seem to be sort of implementing these sorts of policies. But after a while, the government decided that it should do this, and the legislation was implemented in July 2007 rather. It's worth noting that over half of workplaces were already smoke-free due to voluntary sort of agreements that people just didn't want to have smoking in their offices and things. There was virtually universal compliance with the legislation. So there was certainly some public houses and pubs that were resistant, and they allowed smoking, but they were very much jumped on by our enforcement agencies, and they were taken through the criminal process and prosecuted, and fines were issued for lesser offences. So whilst there was some resistance initially, it was only very small and was very much sharply sort of acted upon. And like with other countries, if you can get to smoke-free legislation, these are the public health benefits. So it's reduced exposure to second-hand smokers, as you'd expect, both amongst bar workers and the public. And in the UK, we also demonstrated reduced emissions for heart attacks because of reduced exposure to secondhand smoke and probably reduce smoking amongst smokers as well. And something new that came out of Scotland was published in the New England Journal of Medicine. They found reduced admissions for asthma admissions for children aged 15 and under. So that's a new sort of benefit that's been found. But the secondary objective was to, although the primary objective was to protect bar workers and hospitality workers generally from secondhand smoke, a secondary objective was to try and create this social environment that would enable people to quit smoking if they wanted to. You know, those that were sort of considering, contemplating sort of quitting, and then thought, well, I can't smoke in a pub anymore, so I'm going to quit now, sort of thing. That sort of thinking. So what we did as part of our study is to look at the impact of smoking on smoking prevalence, basically. What we found, this first slide actually just presents or confirms the fact that there was high levels of compliance with legislation in hospitality venues. So, for example, the percentage of people reporting that there was smoking at work decreased from 15% before the legislation to about 2% afterwards. And interestingly, the percentage of people reporting that they smoked in their home decreased from 65% to 55%. So it appeared that there was an unintended positive benefit from this legislation, that it not only increased smoking in public places but also in private places. So it's worth possibly looking at that as part of evaluating interventions in India as well. And again, a significant reduction in smoking in cars as well. So this is an sorry you can't read that so well on the slide, but this is an identical analysis to the one that I presented for the youth smoking. But this time what we found was that the legislation didn't appear to have any additional benefit on smoking prevalence or the number of cigarettes that people smoked each day. So it didn't appear to reduce prevalence. And one of the reasons may be because we had fairly widespread smoke-free places in public places before the legislation was introduced. So, you know, people's work environments, for most people, were actually smoke-free before the legislation. It was possibly only, you know, associated with them going out, having a drink in a bar or eating a meal at a restaurant. That's the thing that changed. So it probably had less of an effect in terms of their, you know, the lesser restricted on them than sort of would be the case in an environment where all workplaces went smoke-free at once. That's what we think that the effect was not as we might expect. Okay, Article 13, tobacco advertising, promotion and sponsorship. So certainly we know that in the UK and in India as well, with direct tobacco advertising has been very much curtailed, which is a good thing. But we've got to also be aware of indirect forms of promotion of tobacco. And one of the emerging areas in terms of you know, promoting smoking is smoking in the movies. And I know that there's been some work here recently published in Tobacco Control confirming that relationship in India. But the initial data, which was published in the Lancet, showed that essentially that the more children were exposed to tobacco in movies, the more likely they were to initiate smoking. And this has occurred at different age groups. And that there's a dose-response relationship, so the more exposure, the more likely people were to initiate. If you combine that with the fact, actually, that this association has been found in a number of countries with diverse cultures, diverse sort of tobacco control regimes, so including, you know, a number of European countries now, Mexico, New Zealand, and India, has led sort of the World Health Organization to actually take some or try and promote some action on this area. I did some work, this is when I was in California, just to document the amount of exposure to on-screen smoking in Britain using most popular films released in Britain between 2001 and 2006. And to summarize briefly, we looked at a total of 532 youth-rated films, And you can see the different ratings on the left-hand, the top of the column there. So the U is the equivalent to suitable for very young children, and 12 is suitable for up to 12, but actually under 12, sorry, over 12, but under 12 is accompanied by an adult. 15 and 18 is the age group there. And you can see that the majority of films released in Britain, and these are largely American films, have smoking in them. And what we did is basically, through a methodology that a number of you will be familiar with, it's basically counting the number of tobacco occurrences in these films, come up with a number, both of the total number of occurrences of tobacco, but also the population health impact. It's important to take into account the viewing figures, how many children are actually seeing these incidents. And so what the term for that is actually impressions, so one impression is actually one person seeing one tobacco episode at one time. So basically we made some calculations and worked out that over that sort of 6-year period, there was about 1.1 billion tobacco impressions or exposures in UK amongst the British youth over that period of time. So a large amount of exposure. What this also found was that because Britain has a much more or less conservative rating sort of philosophy in terms of films than the US, with the US is much more conservative, then for the same films viewed in the US and the UK were much more likely to rate them as child-friendly, and so you had much greater exposure for the same films in the UK and US context. Anyway, so what I was getting onto before is all this sort of information has led the WHO to make recommendations that any future films with smoking in them should be automatically assigned an 18, with the possible exception of a known historical character that actually smoked, or where there's an anti-smoking message contained in that paper. But there's been largely inaction globally on this. I mean, it is fairly recent, but India is the only country to have legislated on this, but as you probably know, the implementation of that is still pending. It's still tied up with, I think, the Ministry of Health and Family Welfare at present, as a response to court action by a Bollywood producer. There's no action in the US, UK or Canada. We had a concerted effort to get some local action in Liverpool, northwest England, about 2 years ago, and this is because local authorities or local governments in the UK are actually have the final say about a film's rating, and we thought that Liverpool, because it had a high prevalence of youth smoking in particular and high prevalence of smoking-related harm, it may be interested in taking this forward. So we lobbied very hard, and I was involved just at the end of this, for the council to implement this WHO recommendation, but they declined to do so. They were concerned that many young people would go to the neighbouring jurisdiction to see their films because they can't see it in Liverpool, and therefore a lot of business, restaurants, etc., would go to neighbouring jurisdictions. So I think the message there is it probably requires national or state level type implementation, that small level areas probably going to be reluctant to legislate in this area. A glimmer of hope is that the UK government has recently agreed to a roundtable discussion with the movie industry and the television industry. So we'll be working on an evidence briefing for that. Now I understand this might be the case in India, but in the UK and certainly in Canada and within US states, governments are very keen to get the US film companies to actually come and produce or to make their films in their countries, okay, because they see it as bringing great economic benefits, both because if you've got a popular film with Big Ben in the background, then people say, well, let's go to London for the next travel or whatever, but also direct economic benefits in terms of employing people on films, etc. So they provide very generous subsidies, up to 25% of the cost of a film, for these film companies to come and shoot their films in the country. So we were interested to say, well, many of these films that they subsidise are youth rated, and many of them actually have smoking in them. Okay, so we worked out the calculation, or calculated the amount of subsidy that was provided to youth rated films with smoking. So this is an indication of the UK government subsidy to the US film industry between 2003 and 2009. So we worked out roughly, we had data on 89 films that got the bulk of these subsidies during this period. And you can see that 55 of these films were youth rated and contained smoking, and those films actually attracted £318 million in subsidies. So if you divide that by the 7 years in which the study was conducted, there's an average subsidy of £45 million, which is 3 times the amount we spend on mass media campaigns. So you can see that you've got a cross purposes in terms of government action here. That on the one hand, they're subsidising films of smoking that we know promote smoking, and on the other hand, they're trying to stop smoking. And so what we're trying to get, and this paper's coming out later on in August, is to highlight this issue to governments and to say, look, if you're going to subsidise films, fine, but you must have the precondition that they don't actually have any smoking in them. In the US, they've taken public health communities being quite vocal on this issue, and you might be familiar, if you're not, there's the Smoke Free Movies website, which has come out of University of California, San Francisco, and I've been working, I worked with the people from there on the subsidies paper. What they've done is, because they've, in a sense, the rating agencies, the MPAA in the US has failed to act on this issue. They've tried to target the film production companies directly through putting advertisements in the trade press, highlighting that obviously having smoking in films has a detrimental effect on youth smoking. And the latest data is actually that this has just come out there's a summary in JAMA where they looked at the amount of smoking in 2010 in US films, and they found that roughly half the big film corporations had actually virtually eliminated all smoking from their films in 2010, but the other half hadn't, sort of thing. So they've had some success in the absence of any government action or rating agencies' action on this to directly target the movie studios. So that may be one, if things don't work out in terms of legislation in India, one way to proceed. I've had my own experiences sort of testing the waters to the extent to which the public are actually supportive of putting an 18 rating on smoking in films. So there was some coverage of a study that we conducted in a newspaper in Scotland, and I was very interested to follow the coverage of this because people have an opportunity to provide comments on various articles, and this is some of the comments that they made. And it seems as if they weren't all together supportive of this idea. So one of the comments was, why not just smoke the academics and let people make up their own minds what they want to do? It's time to rid this country of this forsaken nanny state. Many films show car crashes. Must be time to ban cars. Fools. I'd like to know who pays these fools. Are they taxpayer funded like Ash? And I like the last one in particular. The trouble of education allows numpkins into positions in society to preach to us mere mortals. So you can see that if you're going to try and advocate for these types of policies, you need to have a thick skin and not take things too personally. But this provided much humour at dinner parties afterwards with friends. So, but I'm not sure this was reflective of public opinion in the UK, which I'm not convinced it is. They may have some way to go before the public's on side on this issue. Okay, so just to summarise, I think there's clearly been some successes in England and the UK in terms of tobacco control. Obviously, we've got to a place where smoking in public places is implemented. It's a social norm that people don't smoke in public places. It doesn't cost anything. It's obviously a terrific outcome, and it's led to well-known health benefits. Likewise, the age of sale increase appears to have had a substantial increase or reduction in smoking prevalence among our young people. And there's some evidence that incentivising healthcare professionals directly has sort of supported some patients to quit smoking. And what we've done reasonably well, and that's partly because we've got frequent population health survey data, so we actually be able to evaluate these policies in a timely way, which also takes into account underlying trends. And having looked at the various data sets available in India, it's slightly trickier, so it possibly requires more primary data collection because you don't necessarily have that secondary data available. 35 years to reduce smoking prevalence to from 45 to 21%. Well, that's a disappointment. We want to sort of make more rapid progress in India, hopefully, than that. It's a bit slow. We've still got this persisting problem between rich and poor. Smoking is mainly something that poor people do in the UK, so that's a concern in terms of health inequalities. And I think there's too much emphasis on cessation services and actually supporting pharma. And we've really got to address this issue of government subsidies for youth-rated films. So I'm very much welcoming the opportunity to be here in India. I'm 1 month into a 3-month sabbatical until the end of September, and very much keen to establish a collaborative research program. And I've got a few areas of interest, and I hope to discuss them with some of you either afterwards or at a later point, including taxation, tobacco use, better documenting secondhand smoking exposure, because at the moment my understanding is we've only really got self-reported measures of SEH exposure in India, and so some sort of survey using cotinine might be useful. And the other interest, following up the work I've done in the UK, is to think about the impact of the legislation on youth access to tobacco and also smoke-free public places legislation. So that's it. Thank you very much, and happy to take any questions. Any websites containing details about FCTC? Yes, so you can find pretty good information on the WHO website. If you just Google WHO FCTC, then you actually find the FCTC document itself. Plus there's, I think, every 2 years there's a report on the FCTC progress. So there's a whole host of documents on the WHO website about how we're progressing against the FCTC objectives. So thanks for that question. Is it from Manish? And the second one is to what level has India acted on smoke-free legislation in movies? Okay, so I'm not the expert here, but so the legislation was implemented as part of COTPA in 2005, three? Okay. That was challenged by a Bollywood producer in 2008. I'm getting help here. And currently there's discussions at government level between government departments about the nature of the restrictions, because India actually, the legislation went beyond the WHO recommendations, and it sort of decided that all smoking films should not occur no matter what the circumstances. But those, the status of that legislation is currently under discussion as far as I'm aware. People are nodding their heads, so that sounds all right. Okay, good. So where are we going next to? This is good. This is to, oh, sorry. Okay, I've done that one. So Dr. K, is there a medical curriculum teaching on smoking cessation in the UK? There is a dedicated and well-funded sort of educational component as part of the smoking cessation services in the UK. So it's been tendered out to a group including academics, which ensures that the quality and consistency of smoking cessation training in the UK. So, yeah. No, it's separate from medical curriculum, and so it's for people from medicine and other areas who are interested in providing or being involved in cessation advice. And I'm not sure about the extent to which how well cessation learning is actually integrated into medical curriculum. So that would be something I could explore. Okay, so another one from Dr. K. For UG, is that a partial question? Okay, right, right, right. Okay. Okay, Radhika is saying, you say the only. How do I get through the rest of that? Oh, country. Okay. Can anyone make out that question? Okay, how feasible are tax laws in terms of smoking in India? Well, that's probably not best place to answer that, but my understanding is that it has been tricky to implement increases in taxation in India because the bidding industry, for example, is largely fragmented both in terms of production and sale. So, and you've got much more diversity in terms of the range of tobacco products in India than in the UK. So it certainly is a more challenging environment than the UK to institute increases in taxation. But obviously it's one of the most effective things we can do in terms of tobacco control is to increase tax, particularly to stop or reduce youth smoking. So it's certainly desirable to do that, but there's certainly some challenges there. But I understand that there are some government programs, pilot programs, to try and sort of place and support biddy producers of biddies and tobacco to go into other types of industries. Is every smoker accessing health services referred to a specialist, and how is the referral monitored? Okay, so no, so only a minority of people would be referred to level 3. So certainly the idea would be that many people would be responsive to level 2 brief intervention advice, or even just level 1 type advice. So level 3 is sort of really geared up for people that have a desire to smoke but probably got high levels of nicotine dependence and require that additional support. We monitor effectiveness of the service in that each sort of local area health service, we have devolved a health service responsibility, has to report 4-week quit rates to the government, I think on a monthly basis or even a quarterly basis. And so that's really the main outcome, success or measure of effectiveness of the service. So 4-week quit rate obviously isn't ideal because we know many people relapse, but it's too difficult to follow people up any longer than that. So it's seen as a reasonable compromise to measure 4-week quit rates. So use subsidies for film in the... So what? I can't make out that question. In use subsidies? Yeah, yeah, yeah. Yeah, yeah. I think that, yeah. So no, it's not only in the UK. So in the paper that's coming out, we've documented it in Canada and also in US states. So US states all compete with each other to have films actually produced in their state. So there's huge amounts of subsidies that's provided by US states, large subsidies provided by Canadian provincial governments. There's UK. There's subsidies provided by other European countries. And there's an opportunity to address this actually in Europe because at present the European Commission has a competition sort of function to make sure that there's adequate competition in the area or in the European Union area. And what they're doing is reviewing the nature of subsidies provided by different governments to films, to the film industry. And as part of that, we want to raise this issue of subsidies to films with smoking in them to see if that can be considered as part of this revision. So many European countries also provide subsidies. The Australian government and I understand the New Zealand government as well. So many governments throughout the world are very much keen to support and have US films made in their country. So it's an international issue. No, there's no consideration and that's what we want. That's what we want them to implement. Yeah. Well, particularly if for films that are shown in Europe and the UK, we're less likely to rate films as an adult rating than the US. So films that are adult rated in the US, and those tend to have more smoking in them, but youth rated films have much smoking in them as well, as I showed in the previous slide. So it's a problem generally that there's too much smoking in the films, but at present governments don't consider at all the issue of the presence of smoking or not in a film when they provide a subsidy. So that's what we want them to consider. We want them to say to the film industry, yes, we'll subsidise you, but we won't subsidise any film that has smoking in it. Yeah, and it's widespread in different countries. So yeah. Sure, sure. So India, yeah, yeah. Right, right, okay. But would states provide Indian states provide subsidies to films to produce them? No. Okay, yeah. Right, right. Okay. Okay, that's helpful. So should I go to done those ones, haven't we? Okay, so where am I down? I mean for undergraduate med students. There would be certainly some public health and tobacco control teaching in the for medical undergraduates, but not as much as would be desirable, would be the message for that, or the answer to that question. Okay. When subsidies were provided for the films in the UK labelled youth, how were they counted? Well, nothing has been done, unfortunately, yet. So this is what we're hoping to get this on the agenda as part of this, as a result of the publication that's going to come out shortly. So we just want governments to consider the smoking content of films if they're going to subsidise them. How can we directly pay a patient? This is an interesting debate in the UK because we've obviously provided financial incentives to providers, healthcare providers, to provide advice. But there's lots of interest in actually directly subsidising patients to undertake a number of health behaviours to stop drinking. There's been some pilot projects of subsidising pregnant women to stop smoking during pregnancy, given that in some areas, as I mentioned, we've got very high rates of smoking in pregnancy. So that's the other option in terms of financial incentives. And I know you've got sort of, a history of conditional cash transfers in India. So, that may be an area of development of actually providing subsidies to individuals and patients to quit smoking. So that's certainly an area of development in the UK and elsewhere. Might move on to, it's the same people asking the questions. They're very active, aren't they? I'm working WHO consultant looking east. However, there is much infiltration from adjacent states, and that's the issue that I highlighted in terms of once you've implemented a more strict taxation regime in one jurisdiction, be it a state or a country, then that state is very much vulnerable for tobacco smuggling. And so I think you've raised a good point here in that if you're going to increase tobacco taxation, then you need to ideally support that with some sort of enforcement to stop sort of either cross-state smuggling or cross-country smuggling, be it from your neighbouring countries in this region. Because that's certainly been a major problem in the UK, because as I said, there's this massive difference in terms of the tax regime between the island of the United Kingdom and continental Europe. So they have much cheaper tobacco there. So there's this great temptation for people to illegally bring in over vast amounts of tobacco. But we've been effective in reducing smuggling because in the last 10 years that's decreased from about 20% of total volume to about 10%. So you know that investment of £100 million is probably money well spent to reduce tobacco smuggling. Can you elaborate on what's done? Okay, yeah, well, why not do it in India if there's resource to do that? Very briefly, our general practitioners had a new contract. They have a contract with the government, who's the main payer. So we have largely a single payer in the UK, and they were due a pay increase, and as part of that pay increase, they decided that they pay on the basis of not only the number of patients they have registered, but on the quality of care they provide. And so basically they had a negotiated agreement with the doctors' trade union, and they came up with a very large, detailed program of financial incentives. If you want to look at and find out more information, you probably best to Google the Quality and Outcomes Framework, and you'll find out all the detailed information you need to know about that. But it's the largest what's called a pay for performance scheme in the world, and it's well worth looking into. And as I did some particular interest in that, I'm happy to follow up any email queries. So let's page down. What are the criteria for determining the need for referral level 2 or 3? There are guidelines, and there's certainly an infrastructure in our local health services, be it equivalent of district level services here, to skill up all healthcare professionals on terms of when you should refer a patient to the different levels. And of course, always implementation of that is patchy. It's very difficult to sometimes get our medical doctors along to CPD, continuing professional development type events, but there's certainly been an effort to have a standardized process of referring people. So I might go to deeper. What, according to you, will be the qualification of a specialist for tobacco cessation? That's a good question. I don't have a complete answer to that, but my understanding is that they come from a range of backgrounds. But I think the key thing is rigorous and sort of standardized training, which is what we have in place in the UK. So in terms of this issue of providing, whether we can provide 1, 2, and 3 level type cessation services in India, obviously there's a cost implication of that. And so speaking to some colleagues so far, I mean, maybe the priority in India is just to get all healthcare professionals to be aware of the importance of providing cessation advice, to convince them that actually what they say will be often listened to and maybe acted on, even if it's a small percentage, but they can repeat that advice to different patients. Then they can have an impact on smoking use, to raise awareness of the dangers of tobacco, and to provide a supportive environment for people to quit. So that would be certainly a good start. And then there's the option of exploring level 2, for example, providing some structured training to a small proportion of the healthcare workforce, but that needs to be weighed up against other priorities. Clearly, there's a number of programs that have very good reach in India, and so there's opportunities through maybe the DOTS program and other programs to incorporate tobacco control into some of those programs already. I'm not sure the extent to which that's happened, but there are opportunities. So I think that's all the external questions. So should we? Yes. Yeah.